Good evening. I'm Jim Zirin, and this is The Digital Age. Tonight's show is about the unsustainable cost associated with health care in this country. President Obama says he can finance the new Health Care Reform Act out of cost savings produced by digital technology. Is he correct? How do we curtail costs? And most importantly, how do we curtail costs consistent with improving the quality of medical services which we deliver? Tonight's guest knows the answer to these questions. He is Dr. Herbert Pardes, who is the president and CEO of New York Presbyterian Hospital. Herb Pardes deals with issues of costs and quality every day. And Herb, we are delighted to have you back with us on Digital Age.
Well, it's great to be with you, Jim.
Now, the goal of everyone here seems to be lower costs, better care. How do we get there? What's the way forward?
Well, I think it's got to be accomplished by a number of things at the same time. There is room to make it better. There are things that need to be made better. At the same time, we don't want to, in the spirit of simply squeezing costs, undercut the quality of health care in the country, because in many ways it's very good. But when this bill was crafted, Senator Baucus, who was head of the Senate Finance Committee, met with 6 major constituencies. Those included the hospitals, the doctors, the device companies, the pharmaceutical companies, the unions, and the insurance companies. And he asked for ways.
And you were there, among others.
I was one of the, I was not in those direct meetings, but we were advising the people who were representing us in those meetings. And the president of the American Hospital Association was the actual participant in the discussions, but then he would come back to those of us who represent his constituency. In that process, as an example, the hospitals volunteered to take out $155 billion in costs over a 10-year period as a contribution to bringing the cost of health care down. The pharmaceutical companies volunteered $80 million. The payers volunteered an administrative streamlining, which was projected at a saving of about $500 billion over 10 years. So gradually, by putting those pieces together, one had major contributions toward getting the overall cost of health care down.
But with all that, we're spending $2 trillion annually on health care, and which is about 17% of GDP. It's projected to go up to 20% of GDP. The latest figures show per capita costs are going to increase over 7% this year. Are we really doing anything really to streamline the system to curtail the costs?
Oh, yeah. Well, for example, you mentioned in our opening that the healthcare field is moving in an electronic direction. So that means that ultimately, when fixed or finished, we will have an interconnected system in information technology. And that will mean that patients can have immediate access to their records under their control, that they can then give to their clinicians, no matter where they are, information on their entire healthcare history. So let me give you an example. Patient walks into an office and says, I've had chest pain. Doctor says, have you had a recent electrocardiogram? Yes. Who did it? So-and-so doctor, a couple of days ago. Can we get access to it? Well, no. Well, okay, we'll do another EKG. With a digital system, you can access that EKG directly.
And immediately. Almost immediately.
No, immediately.
Yes.
Because the patient tells the doctor, here's the access to the information. The doctor sees the EKG. No repeat EKG has to be done. Multiply that by the hundreds of millions of times that kind of thing happens around the country. Another kind of example. You're in an emergency situation. You're out of town. Somebody wants to know more about your healthcare history. They can tap in immediately. Are you a diabetic? Do you have a history of epilepsy? Are there other things which would explain your unconsciousness or whatever state you're in? And again, that expedites the treatment, makes for better care, and reduces unnecessary costs and procedures.
Are there also scenarios where if I wanted a second opinion, say from the Mayo Clinic, where you could email my records, my test results, and they could do a consult without my ever having to go to Minnesota.
Absolutely. And as a matter of fact, New York Presbyterian has a system now in which you can directly put all your healthcare information. We did it in collaboration with Microsoft. Other places are doing the same thing. And just as you say, you can give the facility at a distance, Mayo Clinic, New York Presbyterian, Mass General. You give them your information, they can access it immediately, and that again is a big saving. But that's one of only a multiple number of things that are being done. For example, one of the important things is to reduce readmissions in hospitals. People come in with conditions. Let's take a condition like congestive heart failure. They come in, they're in the hospital for a while, they go out, and within 30 days they're back in the hospital again. There's a national effort now to reduce those readmissions. And one of the important things that is needed to undertake it is to ensure that the patient is getting appropriate treatment, and also that the patient is caring for herself or himself in that period post-hospital, so they won't have to come back to the hospital. So the hope is that with that, we will reduce the number of hospital admissions. Let's take another area. We all know that infections have been a problem throughout hospitals. Here, around the world, England, big problem. What we've seen is a close correlation between hand washing by everybody in the hospital and infections. We can show a curve which shows New York Presbyterians percentage of hand washing, people doing what they should do in hand washing, going way up to the 90s, close to 100% now, and the infections go down at the same time. If you have an infection in the hospital, your hospital stay is lengthened, more costs are paid, and therefore by having good hand washing statistics and compliance, one can dramatically reduce the infections.
Also reduces fatalities.
Absolutely,
yes.
Reduce mortality as well. Yeah. So there are a number of things like that. Reduction of falls, for example. People fall, again, they get into trouble, fracture. There are programs now to reduce falls in hospitals. So hospitals are trying to take anything which is an adverse outcome that adds to cost, time in hospital, even as you say, conceivably mortality, reduce those down, and those will be part of the attempt to bring down costs.
Yes. Now, technology itself involves additional costs, which haven't always existed. Certainly in 1964, when Medicare was enacted, there was no MRI, there was no CAT scan, there was no PET scan, and all of those technologies and tests are highly costly, aren't they?
Yeah, but the point is, when they're used well, they provide far better quality, quicker diagnosis, quicker treatment. For example, today, let's take a look at something like stroke. If you go back 30, 40 years, patient walking into the hospital with a stroke, the doctor could do almost nothing. There was an expression in neurology which was called diagnose and adios. I can diagnose you, but I can't do a darn thing with you.
Well, this is what they do in England. They send the patient back home in the care of the GP, and that's the end of the treatment.
Right. Now let's talk about modern treatment.
Yes.
Somebody has the beginning signs of a stroke. First of all, the intention is to educate the public as to what are early signs of stroke, so you can move on this rapidly. If you get to an emergency room right away, you walk into our hospital, within moments we will have you on a series of things which could lead to a medication which can dissolve the clot that's causing the stroke. We can even at times pull out the clot that's causing the stroke and negate the stroke or moderate the impact of the stroke. That again is modern treatment. Technology is important in that. Imaging is important in that. But it's a tremendous difference in quality of life. Now, some of those are going to cost more money. On the other hand, one could say, yes, we want to bring down the costs, but there are some costs that we want because it's going to provide you better care. It's also going to extend longevity and longevity with a quality of life.
Let's look at a moment at economic incentives. We have an insured population. Obama's aspiration is that 100% will be insured one way or another. Now, if I'm insured and I go see a doctor and he says, I can give you one test or I can give you 20 tests, I have no economic incentive to say, well, all I want is one test because that's all I'm willing to pay for. I mean, it's not like buying a car. where the economic burden falls on me for the better car or the luxury car. So I say, fine, give me 20 tests. The doctor has an economic incentive to give me 20 tests. He may not be sure they're all necessary. Maybe he thinks they're all necessary. I mean, he'd settled for 1 or 2, but he gives me 20. Is there something we can do to moderate that phenomenon?
Well, let's unravel. There's several different elements in there. Number one, you're going to find that increasingly people are going to be asked to pay some component of their health care costs. And as you say, if you've got skin in the game, so to speak, you're more likely to be careful in terms of what your expenditures are. The second thing will be greater transparency in terms of where things cost what, and therefore consumers can make a more intelligent choice, again, related to the point that they have some financial impact to themselves. Then let's turn around and talk about the doctor. First of all, responsible doctors should not be giving tests that are unnecessary. And we have, I think the bulk of people in American medicine are responsible, ethical people. There are always a number of bad eggs in any discipline, which is a problem. But let me come back to one other issue which is important in this regard. And that is doctors often do tests for what's called defensive medicine. And that is directly related to one other thing which needs focus. It's been widely discussed, and that is some kind of tort reform in this country.
I knew you'd get to the lawyers.
Of course.
Now, there is data, however, that we're really not paying much more for defensive medicine. And certainly a doctor is to be criticized who prescribes tests because he's afraid of being sued rather than because he thinks the patient needs it.
Well, let me put it this way. First of all, the estimates on defensive medicine are all over the lot. But when you do a survey, and the AMA did one survey, and asked doctors, do you at times do tests because of defensive medicine, 91% say yes. Sometimes these are not unethical or irresponsible doctors, but doctors who face a very real dilemma. If I don't do this test, will I then be sued for malpractice in the event that there's something that was missed or so? So to say that the doctors, are necessarily being irresponsible, as I say, in doing this, I think is a distorted statement. The doctors as a whole, and certainly in our hospital, we are interested in no extra tests and no extra care. You give the care that's necessary. However, malpractice is a real issue. I can tell you that doctors who are put in the situation of being sued find it extremely distressing. In some instances, it's had a major effect on professions. For example, there are very few people who want to go into obstetrics today. The malpractice issues are enormous.
Well, that's the field where the issue really lies, isn't it?
Well, it's one field, but it's happening elsewhere.
I mean, look, it used to be anesthesiology, and then the anesthesiologists cleaned up their act, and they adopted a number of safe practices, and now they're rarely sued.
Yeah, the anesthesiologists did a very good job. You're absolutely right. The obstetricians are also doing as many things as possible to improve safety and therefore make the likelihood of bad events kind of infrequent or non-existent. However, there are instances where a family will have a baby with some kind of defect. The defect cannot be traced at all to physician or hospital malpractice. However, there's a lot of compassion in juries looking at a poor family having had a child or a loss in terms of a defect in a child, and there's a tendency to give awards even when there's no clear demonstration that the doctor or hospital has done anything wrong.
So what would you advocate? No fault liability for obstetrics cases and with some sort of cap on damages?
Well, I think there are a whole range of things you can do. For example, you can have professional courts. So people who really know the facts are making the judgments. The second thing you can do is screen cases so there's not a kind of a flood of cases, many of which have no basis at all. You can put in caps. There are places around the country which have done. Some states have done malpractice reform. A lot of states, however, have not. You can also have other devices by which you insist on professional testimony and make this objective as possible. Another thing you can do, let's say there's a baby who was hurt, and let me just emphasize one thing. My feeling is if there is a hurt to any family, that they should get compensation as swiftly as possible and appropriate to the situation. That's something that should come out of any kind of malpractice reform. However, there are instances of...
I mean, whether there's fault or not.
If there's fault, well, I think one could also consider a system which is independent of malpractice and simply make some compensation to a family where there's a baby with a defect.
Because it's a horrific injury.
I couldn't agree more.
Yeah.
And one thing that all of us want is to try to protect patient and family in this. But there are ways of doing that which don't allow extra cases to be brought when they're not legitimized. I can tell you about cases which had absolutely no case to it. Any objective person would say no, and still the hospital had to defend itself against it and had hundreds or millions of dollars of legal costs, which are unnecessary.
Lawyers would argue that the frivolous cases are being dismissed, that most of the cases are settled and don't go to a jury, and they're settled because the insurers evaluate the case and feel there's a risk of liability. And to tinker with the system anymore would basically immunize doctors who may be at fault.
Well, there are other places around the country where there's been malpractice reform. Texas, for example, it's working rather well. Let me give you an example. In Texas, when they put the malpractice reform in, the tort reform in, we checked with the chief financial officers of hospitals in Texas and asked them what was their malpractice premium now. And they said it was under 1% of their revenues. Well, let's take our hospital at New York Presbyterian is a $3 billion revenue operation. If you were in Texas, you'd be paying less than $30 million a year for malpractice. In New York, in the New York Presbyterian, we pay about 4%, about $120 million. So there's a difference in one hospital of $90 million just for the premium.
Now that's for specialties across the board.
Across the board.
Across the board. Is there any room for reform where people in low-risk practices would pay more and people in high-risk practices would pay less?
Well, there's a certain amount. People
I'm
do
talking
not
about
pay
premiums, yeah.
Yeah, people don't pay the same premium.
Yeah.
So therefore, one of the reasons that very few people want to go into obstetrics is the premium often reaches a couple of $100,000 a year, and they can't afford it. There are no, as I understand it from the Bronx, my Bronx colleagues, there are no individual practices of obstetrics in the Bronx anymore. I mean, that's how far this situation has gone. And it's not just obstetrics, it's neurosurgery, it's emergency medicine, it's surgery. This is a widespread problem. And no matter what one says, if you say, well, defensive medicine hasn't been estimated at X cost, it's there. 91% of doctors say they're doing it, and it's not just a bunch of irresponsible doctors.
Let's get off malpractice, if we may.
Sure.
Is there any room for reforms where hospitals charge for a diagnosis and not for individual steps in treatment? So, for example, if I went into a hospital with diabetes,
yeah.
That they would charge me a certain amount for the treatment, which might involve 3 steps, it might involve 10 steps, and that would be the fee. Now, if it's 2 steps or 3 steps, then the hospital wins. If it's more than 3 steps, well, then my insurer wins.
What you're saying is, could you get a consolidated fee for the treatment of an episode, no matter how long and how many? Yeah, absolutely. There are a number of insurance plans which include that, and that can incentivize doctor and hospital to try to take care of you with as little in the way of procedure as possible. The other side of that, we want them to do enough to make sure they've taken care of the condition the right way. But I think you've got all kinds of variations regarding how payers are paying doctors. But let me just come back. You pointed out malpractice reform is important, but there are a number of things. I pointed out the efforts of hospitals to do error reduction. Hospitals are also working on ways of providing efficiencies. We have a team, for example, at our hospital, which each year works on how do you find efficiencies? Where can you find savings? For example, if you reduce the choices of, let's say, pharmaceuticals or sutures or other materials, you often can reduce costs. If you can find ways by doing systems engineering of having people use their time more effectively, you can reduce costs. At our institution, we've been finding that we're saving for a $3 billion institution anywhere in the range of $25 to $30 million a year by finding various kinds of efficiencies. So I would say that the way to approach this whole problem is to think in terms of shared responsibility. There's responsibility for hospitals, there's responsibility for doctors, there's responsibility for payers. They volunteered that they could streamline the administration of billing and paying. There's a lot of money goes to administration of health care, and take down the costs. The savings were projected at $500 billion over 10 years. That's a lot of money. So what I would say is you want various constituents, including, incidentally, patients, families, and I'll come back to children, in such a way as to, again, bring down costs. Somebody goes out of the hospital. If they take care of themselves, they're likely not to come back out of the hospital. One of the things we've done at New York Presbyterian is instituted post-hospitalization telephone call. We call the patient up. How are you doing? Did you see the doctor we told you to see? Did you go to the clinic we told you to go to? What's the dose of medication you're taking? What kind of medication you're taking? And we find there are a lot of mistakes in that handoff. So we're focusing more and more on how is the information transmitted to patient in such a way that the patient does their job, keeps themselves well, and hopefully doesn't have to come back into the hospital.
Are you also saying to them, do you exercise and are you cutting salt out of your diet and stop eating trans fats?
Doctors should, many of them are, but all of them should be taking on the role, as you're implying, of preventive and prophylactic strategies by the patient herself or himself.
That can save a tremendous amount even in the geriatric group, isn't that right?
Absolutely, and let me extend it further, because I think there's one thing that should be considered which would help this notion of citizen education and as a result prevention. My feeling is there should be a relook at what is the curriculum on health, nutrition, how to live a good life for children from day one. If you can start children in kindergarten learning about health, nutrition, exercise, and all related issues, and that's made as important as math and history, you should grow up a population of people who really are dedicated to taking care of themselves and having good health.
Well, I didn't start as a child, but I did have an apple this morning, so I'm sure you would have approved of that. Let's, if we may, talk about the new Health Care Reform Act, which the Republicans like to call Obamacare. Speaker-elect Boehner said about the bill after his victory and the victory of other Republicans in the midterm congressional elections. He said, quote, "We think that Obamacare ruined the best health care in the country. We believe it will bankrupt our nation. We believe it needs to be repealed and replaced with common sense reforms to bring down the cost of health insurance, and you'll see us move quickly enough." Now, do you agree with him that it will bankrupt our nation, that it needs to be repealed, that it ruined the best health care in our country?
You know, hyperbole on the part of either party really is usually off the mark. We have a very mixed bag here. There are some very good things that the new health reform did. For example, it excluded the requirement to not have a pre-existing condition in order to get insurance. That's a wonderful development. It eliminated the notion of lifetime caps on insurance, another wonderful development. It allowed families to keep their kids on till they were 26, which is another good development. So there are a lot of good things there for citizens. The other thing it did was it increased the number of people who would be insured, and that's important. There are some things that I would have wanted to have done in a somewhat different way, and maybe there will be some reconsideration of that. But we've got a very mixed situation regarding politics. A Democratic Senate, a Republican House, a Democratic president. I would hope they can get together on some things. But a lot of the things that were in health care, that were in the plan, are positive, and we don't want to lose those.
Well, suppose Congressman Boehner called you this afternoon and said, "Herb, I'd like you to advise me on how we can modify this bill. We know we can't repeal it. Right. And if we ever did, Obama would veto it." So what would you tell him?
Well, I was not a big fan of the so-called Medicare Commission. I still like the fact that we elect our Congress people, senators and and congresspersons, and I like them to be overseeing kind of the cost of care and the rates of care and such. So setting up an independent commission was not something I liked. The second thing I was concerned about was a cut in the payments for indigent care. What they did was they said, we're going to get a revenue stream as a result of covering people who are currently uninsured. We're going to put them on a Medicaid-like program, and as a result, there'll be revenues coming to hospitals. In return, we will cut some of the indigent payments we're making now. The problem with that is it's very uneven around the country. So New York, which happens to be a very generous state in terms of access to Medicaid, has much fewer patients who are uninsured. The problem in New York is underinsured and undocumented people. As a result, the revenues from this covering of the uninsured in New York will be slim. The revenues in many other states which had a much tougher Medicaid program will be great, and so some states will get windfalls and some states will get a short straw.
Unfortunately, we have to wrap up. Herb Pardes, I have a question for you. And the question is, can digital technology contain our healthcare costs?
Digital technology will play a large role in reducing down healthcare costs. It's a great development.
Herb, this has been absolutely marvelous. Thank you for coming by.
Always nice to be with you, Jim.
Wonderful to be with you. And thank you for coming by. Tune in next week for more on the digital age. Don't forget to visit our website, www.digitalage.org. For the Digital Age, I'm Jim Zirin. Good night and all the best.